This was the other thing that I mentioned a moment ago that we need to look at. Um, this is an ectopic pregnancy is whenever the egg is fertilized, implants, and grows outside of the endometrial canal. In other words, it is fertilized, it attaches somewhere other than the inside the uterus, and a lot of times it will attach in the fallopian tube. Um, and because of the size of the fallopian tube, it can't grow there. And it's once it attaches, it's not going to implant anywhere else. So that's where it's going to grow. Um, the cause really don't know. There's a thought that maybe scarring or something that slows down the process of it moving into the uterus may obstruct and cause it to grow there. But a damaged fallopian tube, um, something like that may be a part of it. Um, Prior surgery in the pelvis, IUDs are another one that's considered maybe a possibility of increasing the likelihood a little more. Symptoms: sudden onset of severe lower abdominal pain, vaginal bleeding, no pain or pain on one side only. They'll have a positive pregnancy test. Um, Now, the extreme cancer situations, this can be life threatening. Um, Typically, there may be no pain at all, um, and they may have a negative test, but typically it'll be a positive test. And whenever they look with the ultrasound, there's nothing in the uterus. And then sometimes they can actually, with ultrasound, look around and actually see that uh, ectopic pregnancy in a tube. Um, and they can look at the serum HCGs and tell a little bit of where they may be concerned of them going into this state. So that's a little bit of a warning. Diagnosis: the big risk with these is if they are allowed to grow for too long, they'll rupture. And At that point, then they can have a considerable amount of blood loss. So you want to diagnose it early. Usually that's again by ultrasound. They may put a needle in the uterus with a cholecystectomy and use some of that to as a part of the diagnosis if they're not sure. Um, then typically they will do a laparoscopy and remove that area. Typically, whenever it's in a tube, they will have to remove that tube entirely. Laparoscopic surgery is done to terminate the pregnancy and remove the fetus and the placenta because it can't be permitted to grow there. There's no space. There's not enough blood supply. If it's in the tube, it's going to explode the tube and at that point cause a significant amount of bleeding. So replace blood loss is another thing. If they're having extensive amount of bleeding, they may have to sacrifice an ovary. They may have to, or they would probably sacrifice an ovary. They may sacrifice a tube as well. But other medication treatments would be potentially methotrexate. They might do that instead of surgery. That will also help to terminate the pregnancy. If it has not ruptured. And basically what it does is causes it to dissolve. And so it actually does the same thing a surgery would do, just a different method. Not all patients may be candidates for it though. Premature labor, contractions leading to cervical change before week of 37. Now this is key in leading to cervical change to define it as labor. Symptoms: contraction, cervical change, increased discharge, um, and they'll look at the at a vaginal exam, ultrasound looking at the cervix to see the length of the cervix, see that the cervix is not changing, um, and look at the contractions and so forth. So, a number of causes or contributing causes to premature labor, including smoking and stress. And of course, there's always those cases of um, domestic violence that sometimes can increase during pregnancy. But maternal infection would be one. Um, Abnormalities in the uterus itself, uterine fibroids, that's those gross or tumors in the uterine wall. Maternal age, older mothers are more potentially, and by older we're just saying maybe over 37 or so. Gum disease, infection, no prenatal care uh, creates a higher risk patient as well. Treatment for premature labor. Um, there's really not anything specifically um, that will prevent it really. And really early on, they may not try to prevent it too much. Um, but it becomes to monitoring patient, looking at fetal heart tones, making sure still viable, fetal movement. Um, they may look for cervical changes, and especially over a shorter time period. Um, of course, one of the goals is to prevent delivery too early so that the baby has greater risk of survival. Um, and then the earlier in pregnancy this happens, the greater risk of it not going well too. The only clear treatment is to use IM progesterone injections, and they're going to look at that very carefully to making sure that this is the right choice for this particular patient. Fetal movement is a pretty good indicator that the fetus is doing well and it's getting enough oxygen and not having any significant problems. Um, They usually will want them to chart the fetal kicks beginning at 28 weeks, until they deliver. Now, not all doctors do this, but they will want them to observe what is normal because babies don't always move even in the uterus at the same time exactly every day. So they don't always get up in the morning and go to bed at night. They may be moving at other times as well. Um, but each office is going to have its own guidelines there. Um, any concerns about movement, reducing movement, and all is going to require that patient coming in and evaluating. Preeclampsia, or also called toxemia and eclampsia, it is serious. Basically, this patient, their blood pressure is elevated. They're spilling protein in the urine. If you remember in the urine system chapters, um, spilling of protein means it has already reached its maximum capacity to control, so it's spilling out. Eclampsia is whenever they are to the point of developing seizures. Um, Most commonly, you see this in the third trimester of pregnancy, but you could see it at any point, but usually see it later stage pregnancy. Some of the key symptoms that you're going to see with preeclampsia is a sudden weight gain. You may have seen them last week, and they weighed one particular weight. And remember, this is happening later stage pregnancy. You see them again today, and they looks like they've gained 5 or 6 pounds according to the scale. That's probably not true gaining weight. They'll also have swelling in their hands and their feet and so forth. They'll have headaches. Um, Visual disturbance is another one that you see more commonly, and then they're going to have protein spilling out in the urine. Abrupto placenta is something that you do see occasionally. It's not extremely common, but it's where uh, the placenta prematurely comes loose from the wall. So when it separates from the wall, it causes bleeding to the point of hemorrhage, abdominal pain, fetal distress, and if they can't resolve it quickly, it'll be in fetal death. Um, A lot of times they don't know what causes it, potentially being preeclamptic or being hypertensive or another group of other reasons. Um, Infection could cause it, drug use could cause it, and so forth. A lot of times I'll refer to this as placental abruption, but the true terminology is abruptoplacenta. Um, they'll have bleeding to hemorrhage, they'll have contractions that are painful, they'll have abdominal pain, they'll get into fetal distress for one reason, blood loss, and then fetal heart rate becomes abnormal, and the fetus can at that point die. If it is extensive, then they want to move quickly on it. The more severe, the more likely that the mother's going to have a blood loss issue. They're not going to be able to clot, um, and occasionally you can detect it or the beginnings of it on an ultrasound. Treatment, hospitalization, because these patients can have a significant blood loss, bed rest. They may induce labor if they're near term. Um, or the bleeding is such that they are concerned about it. Uh, Quite often, these will end up with a C-section delivery, especially if the fetal heart rate goes down, or if they develop placental shock from the blood loss. Um, so, number of things that you look at with these. Um, In placenta previa, this is where the placenta covers the opening of the cervix. So in this case, the placenta is coming down before baby comes down, which can happen. Now, sometimes the placenta implants low, which poses a problem. We see it more commonly in the first and second trimester, and usually it has lifted away by the third. Um, Basically, in a partial previa, most of the placental tissue is free of the cervical opening, so it's only a precautionary stage then. Um, if they've had a C-section before, they may be at greater risk of placenta previa. In this case, what's happening is the placenta is tearing away from the wall. So they'll have painless, bright red bleeding. The abdomen will be soft. Um, Vital signs may start to look like hypovolemic shock. And then fetal blood supply is going to become an issue as well. Um, so all of those things mean a very quick observation of the patient, making sure where you are with them and the problem. Um, they'll do an ultrasound that looks at placenta, see where it's implanted, and as the cervix begins to dilate, the vessels tear loose and the placenta bleeds. So uh, this is something that we have to monitor very quickly. Some cases of placenta previa are not really complicated, so they may be able to continue their normal daily activities without any problem. Um, if there's any bleeding, then they're probably going to suggest that they um, don't discontinue exercise, intercourse. Um, Again, in most cases, these are simple enough, or the placenta moves up over time to where they're not a problem. The problem becomes whenever they are closer to term. Um, so if they have bleeding, depends on how significant the bleeding is. They're going to monitor them in the hospital setting, and if they determine that the bleeding is very significant, they're probably going to go ahead and do a cesarean section, um, because they can have a hemorrhage, they can have a fetal or maternal loss as a result, um, and they will require if at term, they will require a cesarean section for delivery. They cannot deliver vaginally.